Welcome back to the Inside Athletic Training Podcast. Today we're joined by Dr. Cameron Roth and Andrew Rizza, co-hosts of the Behind the Sports Medicine podcast, for a wide-ranging conversation on where the profession of athletic training has been and where it's headed. The guys share their thoughts on the evolution of athletic training, the growing role of technology, collaboration, and research in modern care, and their perspectives on how sports medicine continues to adapt across all levels of competition. Enjoy the show. All right, welcome back to the Inside Athletic Training Podcast. Excited to be joined by two extremely experienced sports medicine professionals today and also co-hosts of the Behind the Sports Medicine Podcast, Dr. Cameron Roth. He'll go by Cam, and Andrew Rizza. Guys, great to have you on the show. Thanks for making time this morning. Before we get started, I want to kind of toss it off to each one of you to share a little background information with our listeners about how you got to this point in your career and kind of everything you've done. So Andrew, we'll start with you.
Yeah, Sam, thanks for having me. So I've been an athletic trainer for almost 30 years. Kind of got into it like most people do. You're an athlete, you get injured, and what do you want to do? You want to try to help other people the way people have helped you. So went to Northeastern, got my undergrad, went to graduate school there for healthcare management and leadership, and then got another master's in applied sports science analytics. I've been at a small town outside of Boston, town of Weston, as the athletic trainer there for 28 years. I previously was at a Division III college, all women's school for 2 years before that. And I'm also a clinical director for a pretty good size private physical therapy practice in the Wellesley, Massachusetts area. Met Dr. Roth. Cam, what's it been, 20 years? Cam was an athlete that I worked with at Weston. We'd always stayed in touch. And I started this podcast 2 years ago, and he was my second interview. And Cam said, "Hey, you ever want to co-host? I'm your guy." So a year ago, about this time a year ago, we had joined forces, and here we are today. So
awesome. Cam, how about yourself?
Yeah, Riz is the brains behind the operation. So I was a Weston High School student from 2003 to 2007. So I met Riz in 2003, and we've been friends ever since. So it's 23 years later. I'm an orthopedic upper extremity surgeon in the Phoenix area. I trained in Chicago and then did my fellowship training in both Boston and abroad in Switzerland. So I specialize in shoulder, elbow, wrist, and hand surgery. And then out here in Arizona, we're lucky enough to have about half the Major League Baseball teams out here for spring training. So right. I help take care of the Chicago White Sox in Glendale. A lot obviously during spring training, but we have a team here year round, and then all the professional players come here for rehab assignments. So we'll see people throughout the year, whether in the office or down at the facility. And, Riz started this podcast. It was a great opportunity for us to reconnect and then reconnect with our actually ever-growing large community of people we've known over a long time. And it's been a lot of fun, and we're happy to share some of our experiences. But honestly, we've learned a lot from so many people that we've talked to, and it's been fun increasing our connections. So.
Absolutely. And Andrew, you mentioned you started the show. What was your kind of initiative or reason for jumping into this? I know it's a much different undertaking than things you've been used to in your career, putting yourself out there, having guests on the show, doing all the behind the scenes things. What was kind of the reason? Were you just looking to do something different, share your knowledge, help people out there? How'd you get started day one?
So I was talking to a colleague of mine, and I had this idea of doing this, and I'm not a media person. I'm not tech savvy whatsoever. Did a lot of research on how to do this and how to get it off the ground as inexpensively as possible, but really to share the message. I mean, I deal with patients all day long. I deal with athletes all day long. We talk to parents all the time about injury, trying to share that with peers and colleagues on how to get better as athletic trainers, physical therapists, surgeons, however we treat that population. But also for the consumer to understand where they can go, how they get help. A lot of people don't know where to go. It's until they come to see us, they understand that. So I figured, why not use media and try to get it out there on how to be better at what we do, but also for our peers and colleagues to do the same.
And Cam, you like we mentioned earlier, you were a guest on the show. I think you said second ever. You guys have been doing this for a while now. Pretty cool to see how far you've come. What was it like for you jumping in as an orthopedic surgeon? Clearly super busy working with the White Sox and doing a lot of things. What made you decide that, hey, I want to be part of this?
Oh, it's just an absolutely incredible opportunity. I mean, people have access to so many resources now, and unfortunately, there's a lot of bad or misinformation flying around. And one of my big charges in practice is transparency. So it's very difficult for people, even with good medical literacy in big, robust cities, to see subspecialists and get appropriate information, have a subspecialist spend a legitimate amount of time with them when they walk out feeling satisfied and well-informed. And I try to do that in my practice. But this is also another opportunity, another outlet for people to see, oh, that's an orthopedic surgeon, but he's also a regular person and a father and a friend. And what he's saying, I can definitely trust that person, because we're not promoting anything. We're not influencers. We're just here to talk about our experience, what works, what may work, what definitely doesn't work, and then talk to people who are legitimately experts in their field. And we want to just share good information and create this community. So when patients come into Rizza's clinic or my office, people are well informed, they feel more comfortable, they're less anxious, and that overall leads to better patient results.
Yeah, that's definitely something I wanted to touch on with you guys today was, you've had so many different variety of guests, from Brad Pearson, medical director with the Boston Red Sox, other people outside of the PBAT space, triathletes, people from the NFL, so many different sports and different professions that you've had on, all relating back to sports medicine. When you guys are picking guests, I know you want to get information out to the public. Maybe it's like youth arm sports specialization, things like that, but also more detailed stuff about athletic training and sports medicine, which you're most passionate about. How do you go about balancing, providing so much detailed information to one audience versus simplifying things that another audience might?
What I've actually noticed when we're preparing for guests is that a lot of our questions seem to have a similar theme. So whether we're talking to Dr. James Andrews or Ted Johnson from the Patriots, or as you mentioned, Brad Pearson or Isaiah Kazavinsky or any of these players, it always comes back to a few key topics. So some of these topics are their journey into how they got there, mentorship, recovery, and then what they've learned from their experience. So what was different 20 years ago to what do you see now, and what is your opinion on that? And then people's opinion, especially Ted Johnson, who played in the NFL for the Patriots in the early 2000s, and then being a media member now and talking about her, Dominique Foxworth from ESPN, or even Dr. Andrews, like how has shoulder labral surgery evolved over the past 45 years since you've been doing this? And that is, there's research studies and randomized control and level 1 evidence, and that's very, very important for guiding our decisions in the clinic and operating room space, or in the training room space as well. But what I think may be undervalued, and as I'm learning this as I continue to grow in my practice, is level 5, what we call level 5, or anecdotal evidence. So hearing Dr. Andrews tell us 45 years of experience operating on the highest level athletes, and what his experience with shoulder and knee surgery is, I take that personally as a young orthopedic surgeon. I take that as gold. I take that just as seriously as a level 1 randomized controlled trial. So it's really their experience and advice, and what has gone right, and then more importantly, what has gone wrong and what they've learned from it.
Yeah, that's great. And we've had some guests on the show who you're kind of blown away by their experience, and you kind of catch yourself in awe listening when you're trying to have a conversation. It's always fun to have those moments. Andrew, when you kind of got started here, was there a guest, maybe it was Dr. Andrews, who's an absolute legend in the field. Was there a guest who you wanted to have on the show who you still haven't, or someone you have had on the show and kind of like a wow kind of moment that you booked a really awesome guest? And do you have any favorite episodes thus far?
Yeah. So, I think Cam and I both are pretty big sports fans, especially Boston sports fans. Okay. So we have people that are from our region that we had watched through the years, like a Ted Johnson or a Mike, Kurt Schilling,
Sure.
or, somebody that's within that realm. Like, it's like like that's a professional athlete, but also, like Cameron mentioned, like we want to hear what their experience was. So when we interviewed Isaiah Kazavinsky, who's a good friend of mine, played at Harvard. I went through the Harvard Sports Medicine athletic training program when I was at Northeastern.
Mm-hmm.
So to experience working with those athletes and then seeing them after and what they've become, for me was important, because then I really had that connection, athlete to then person that is now in the real world working and being a professional. My first guest that I had on was Carl Gustafson. And Carl had hired me 30 years ago, and he's a mentor and is still a mentor to me.
Wow.
He opened a lot of doors for me throughout my career. And I owe a lot to him and his experience and expertise as a physical therapist, owning a practice, building the practice, becoming the therapist that he's become, but introducing me to all the people along the way, all the physicians, how to operate within our confines as athletic trainers and physical therapists meant a lot to me. So having him on kind of kickstarted this whole thing. And it allowed me to look more at that mentorship piece and how we're going to now shape this podcast to be able to provide the information we want to provide to our peers and colleagues. But he was probably my favorite thus far, besides Dr. Roth here. But I think,
the most important one, right?
Yeah. When we interviewed like even Dr. Andrews, I mean, we've known about and seen Dr. Andrews operate as a physician for my whole career. Mm-hmm. And to think that we got him on the podcast, someone that is the elite of the elite, blew me away. And most everybody we've had contacted or reached out to come on, without a doubt, has said, yeah, sure. When do you guys have availability? There's never been that person that said no to us, which is humbling for us. But also, there's still a lot of people we want to reach out to. So the connections continue to grow through the foundation and the audience that we've built so far.
Yeah, that's awesome. And a testament to, if you have a couple big guests on the show, you can always share that information and people wouldn't have an issue following Dr. James Andrews for sure. Well, I want to shift gears a bit here, guys. You guys work as athletic trainers or with athletic trainers all the time. Our primary audience, obviously, the title of the show, Inside Athletic Training. All of the PBATS membership are major and minor league affiliated athletic trainers. I want to talk a bit about that role and how important it is in baseball specifically, but across all sports. Cam, I'm wondering from your perspective of orthopedic surgeon who communicates with athletic trainers. You're working with the White Sox, great staff there with James Truck and the guys. How would you guys describe kind of the evolution? You talked a bit about evolution of everything and James Andrews doing surgeries. How would you describe the evolution of the athletic trainer over the years you've been working in baseball? Has anything changed dramatically for that role outside of obviously major things like innovation of technology and data? What have you guys seen, Cam, specifically, the change for the athletic training profession?
So obviously taking care of a patient, especially a high-level athlete, is not just a one-person job. Mm-hmm. And you learn this early in your training, no matter whether you're an athletic trainer, physical therapist, hand therapist, orthopedic surgeon. You learn that it's a team approach. That's why we're all attracted to this field, and that's why we work in sports medicine. So, with the team specifically, the athletic trainer works day to day with these patients and knows all these patients, can recognize all, 250 athletes in the facility by mm-hmm. name and know their whole history, and they really see them on a day-to-day basis. And then we're there for extra support. Hey, can you look at this MRI? Hey, can you evaluate this patient in the facility? He's been having, latissimus pain or shoulder pain or knee pain, or he strained his hip or something like that. And it's really about constant communication. So you can see like James and Kevin, these guys are always on their phone, but they'll always respond to me, but they'll always be talking to the guys in Chicago. They'll always be talking to management and the other trainers, and they'll be texting the players, whether it's in English or Spanish or communicating with the Japanese interpreters. And it's really all about communication and ensuring like a safe, efficient treatment plan for these players. Okay. Do we need imaging? Yes or no? Let's get some imaging. Okay. Who's going to look at the imaging? Hey, Cam, are you in clinic? Can you pull up the MRI? Can you look at it? What do you think? Can you come down to the facility tomorrow and examine the patient? What do you think about return to play? We talked to the guys in Chicago and they want him on this rehab protocol. Would you agree with that? Yeah, I think that's okay. For the next week, let's do this. Let's put him in a brace, return to play as tolerated, something like that. So it's all about communication. And obviously, these guys are at the highest level. They have come up through the ranks, both James and Kevin and everyone who works underneath them. So they're very professional. They're very, very smart. They're very, very experienced. So it's a top-notch facility and top-notch organization. And I'm sure every other MLB team is exactly like that. So, it's actually relatively smooth on our side down in Arizona. It may get a little choppy up in Chicago sometimes, but the Chicago docs are also very, very professional, very, very experienced. But I can see on a day-to-day, when you're grinding every single day, 162 games a year for the athletic trainers, it can wear on you for sure.
Yeah, that's the communication aspect is pretty wild. I had Kevin Pilfant on the show a couple months ago, I think, and just hearing him talk about how many people, not that he's in charge of or overseeing, there's many of those, but how many people he's invested in communication-wise, from the front office to James to Josh to everybody down to the guy who's working his first year at in the DR rookie ball. It's wild how much he has his hands on as the medical coordinator. So cool to hear you echo that statement there. Andrew, so back to the original question, athletic training has changed so much. What's been the biggest change in your eyes from when you started, when you got into this, from when you were a student even to today and everything you're doing?
I think the biggest change is that there's so many people that are there as specialists to help out the teams. So, for instance, when I started 30 years ago, or a little over 30 years ago, it was just the athletic trainer acutely treating the athletes, but then you weren't doing the rehab. So now you fast forward 30 years and you see athletic trainers that are helping to manage the care, get the referrals for the athlete to the specialists. Specialists are coming into the clinic, whether that's hand, elbow, wrist, knee, shoulder, spine, nutritionist, mental health specialist. All of that stuff now is part of the healthcare team. We didn't have that 30 plus years ago. And you had to build that as you went. And the one thing that I've learned, and going back to speaking to Carl and one of my other mentors, Dr. Thomas Gill, he said, you have to be able to build a healthcare system or healthcare team that's going to help you with the management of your athletes to give them the best care possible. From that day forward, that's when I went and introduced myself to all the fellows that came through, any residents that I met, knowing that we're in the hotbed in Massachusetts, and these are some of the orthopedics that are probably going to be here and stay here. But it's a good way for us to market each other and talk to each other about getting these athletes in as needed. So the healthcare system has changed. It's really a 180-degree shift from where it was. And speaking to Brad Pearson, he said the same thing to us when we interviewed him. When he started, it was, you're going at the bottom level of minor league ball and you're working your way up, but you don't have everybody available until, 15, 20 years ago, where all of those people started to be part of the healthcare team. So for us, it makes our life easier, but we also know that our athletes are getting everything they need when we need it.
Mm-hmm. Yeah, it is. Brad's a good example. Obviously, the Red Sox staff, as I'm sure you mentioned on your show, is massive. They travel with probably more people than anyone. Kudos to them for having the resources. But these staffs, so in the day were essentially a head athletic trainer and assistant, and a lot of them were wearing baseball pants, and it was a different game back then. So it's really cool to see the evolution. Andrew, I want to kind of follow up on that, with your experience in the clinical setting and also high school athletics and everything. How do those differ? Obviously, winning is priority in Major League Baseball, maybe different from the Dominican Academy where development is priority. And then down, you keep going toward development. And then there's younger kids. How does the athletic trainer who may have his sights set on a bigger role in the future kind of balance, okay, I'm starting in the high school setting or here or there, and kind of stay present in doing that job? Do you have experience kind of with those feelings personally?
Yeah, so I think the biggest thing is if young athletic trainer coming out that wants to move up in the profession. I think starting at the ground level obviously is something that helps to build experience. I think the more experience you get in the level of, if it's specifically baseball, is understanding the biomechanics of baseball, understanding the injuries that can occur in baseball specific to that sport. Because other sports, as you know, have different injuries, similar orthopedically, but mechanically they're different. Understanding some of the overuse syndromes that you're going to see, working with the local, again, orthopedics on how to get better at what you're doing, but also think of strength conditioning staffs that are in the area to help you. I interviewed Eric Cressy before Cam came on, and Eric and I spoke about this. Like when he started out, he was working with high school athletes as a strength conditioning coach, became the Major League Baseball guy, and now is down in Florida running this massive academy where he also now works for the Yankees. Mm-hmm. So to get to that level, it's not always a quick jump into the pro level. It's, hey, work your way up, get the foundation. You need to build the foundation to build your house. So if you can do that, understand it, and get better at doing your craft, then you can definitely get there. But it takes some time. It takes some work.
Mm-hmm. And Cam, similar question to you. You're working with big leaguers. That's the highest level there is, but you're also working with other athletes. Is there something, not necessarily that you enjoy more, one patient versus the other, but are there certain aspects of each group, subset of athletes that you work with that you take something from and enjoy kind of differently? Maybe it's the pressure of working with a big league athlete versus the development of a younger one. Is there something that you kind of find yourself leaning towards in terms of the passion for what you do every day?
I actually don't think there's much of a difference.
Okay.
I think it's cool to see. So in Major League Baseball players and minor league baseball players, you see pathology, which is actually accelerated. So you see a 26-year-old shoulder in a major league pitcher, which does not look like your traditional 26-year-old shoulder. It has the pathology of someone who's been using their shoulder for much, much longer. It's because these guys throw 96 miles an hour, right? Mm-hmm. So to be able to see pathology on an accelerated level and everything you've read about and everything you trained in, to be able to see it almost continuously, because it's really selection bias. You're really getting the highest level of shoulder injury and shoulder pathology. Whereas in your office, you have a lot of people who come in and maybe they played too much golf over the weekend. And that, a little bit of ice, NSAIDs, Medrol dose pack, a little bit of passive active motion, maybe some therapy, and they'll be fine. But, these professional baseball players, like we had a minor league player in spring training who was having some armpit, posterior shoulder pain, some latissimus tenderness. We got an MRI. He had a lat tear. I mean, this is a 22-year-old AA pitcher who has a lat tear. You don't get that kind of stuff just walking into your office on a daily basis. So you really see a really concentrated amount of sports pathology, which obviously unfortunate for the athlete, but for a learning and growth perspective as an orthopedic surgeon or athletic trainer or physical therapist, it's incredible.
Yeah, definitely. I'm sure you see a gamut of things in the office and so much different cases there. One thing I do want to talk to you both about, there's so much chatter about youth sports specialization, arm health for that matter. Things have changed from when we were all growing up and playing sports. There were no pitching labs. I grew up in Wisconsin and you played baseball in the summer. It was warm. You could go outside and throw the baseball around. In the winter, it was basketball, fall, football, as you guys know, from the East Coast as well. Andrew, I'm curious your thoughts on youth arm health in general. A lot of Major League Baseball guidelines are being put into place, pitch smart programs, dead periods, things like that to kind of limit that pressure to be ready to go year round. Do you have thoughts in general on kind of the youth arm health epidemic that we've been seeing recently?
Yeah, it's an interesting question because when we spoke to Dr. James Andrews, he spoke about the pitch smart and how they kind of put that in motion. And we've been dealing with it for a long time. In the Northeast, it isn't as prevalent. I mean, we have winter ball where kids will go and they'll throw and they might hit, but they play another sport, most of the kids that I deal with. We do see the elbow and shoulder injuries, though, from the kids that are, they might be throwing in a high school game and they might be playing at the tail end of high school. They're starting to pick up their summer programs.
Sure.
They might start to see that. I think if you have a great program set up for your pitchers and your infielders to be able to follow, you can help to help them to stay out of the athletic training room when they're injured. So rotator cuff strains, elbow pathology, even some nerve cubital tunnel stuff we might see. Very rare, but you may see it. The one thing that I took away from a conversation I had with Eric Cressy, he said what they're seeing a lot of with youth baseball is that these kids are playing 12 months out of the year in some of these warm climates. And he said, if you show up to a September baseball game and there's a person behind the backstop with a radar gun, he said, run. He said that's one thing that kids and parents should not see because that's going to set them up for failure, especially at young ages when they're trying to chase getting into college or getting into that higher level. So for us, we have a lot of conversation around that type of activity with athletes, how to stay strong, how to make sure they're dosing their pitching and their workouts correctly, and making sure that we're minimizing the trauma. Unfortunately, as high school athletic trainers, you typically hear of these things when it's too late. So for us, we have kids that come back in the fall, start their fall season like, oh, you know what? I've had elbow pain all summer. Well, when did this start? Well, the end of my junior year, it started in June. Well, why didn't we hear from you? So I think the one thing that to take away for parents and coaches and athletes is to make sure, one, you're following the guidelines. Two, your kids are doing other sports besides just baseball. So they have that change in dynamic structure, and that they're also not creating something that they cannot kind of get away from. So if they start to get elbow pain, the chances are they're going to continue to have that if you're not treating it, right? And they're going to end up in Cam's office seeing him for a UCL reconstruction, which we don't want. So I think, again, in the Northeast, we don't see a ton of it, but I know it's out there because kids are starting to become more and more specialized with that sport.
Yeah, and Cam, on your end, like Andrew just mentioned, kids show up at your office and there's elbow pain or there's shoulder issues, younger kids for that matter. Is there advice you're providing to parents who may, like we mentioned at the outset of the show, may not have this access to information, may not be in a city where they can go see somebody? Is there kind of baseline advice that you would provide to the listeners out there who are like, hey, what do I do with my son who's having these issues?
Yeah, so I live in Arizona, so we have year-round baseball, and it's an absolute epidemic. Yeah. So Riz mentioned Dr. James Andrews and Pitch Smart, so I talked to them about the 80-80-80 rule, which I'm sure everyone who listens to this show is familiar, but it limits the amount of innings pitched, and then you have to take at least 4 months off, and then you can't pitch more than 80 pitches in a game. So, and that through the MLB is designated for ages 9 to 12. But honestly, I think that extends, in my opinion, all the way up to through high school. So I talked to them about that. I also talked to them about scapulothoracic dyskinesis, because when you have abnormal movement of the shoulder blade in your pitching, if the energy will actually travel to your elbow, and as you know, your elbow can only handle a certain amount of energy, and that's what's happening to these kids. They're getting a lot of valgus stress on their elbow and too much energy going through it. So their ulnar collateral ligament is either stretching or having partial thickness tears, or in the worst conditions of full thickness rupture, and then they have elbow instability. So I'll talk to them a lot about periscapular muscle strengthening and working with either an athletic trainer or a physical therapist to work on their periscapular and rotator cuff muscles at any age. And I'll show them. So what I'll do is I'll have them turn around in the office and I'll lift up their shirt, and then I'll take a video of their shoulder blades as they're doing active forward elevation and abduction. And then we'll sit down with the patient and his or her parent and actually look at the video. And you don't have to be a rocket surgeon to see how the shoulder blades are dyskinetic. So it's helpful to give them that information. What I have noticed a lot is when we're doing physicals for the team, the majority of the minor league guys or the guys who are coming out of college all have medial elbow incisions. A lot of them have had Tommy John in high school, and Tommy John is not a benign procedure. I mean, the ulnar nerve is there. Sometimes you need a ulnar nerve transposition. You can have residual cubital tunnel symptoms. You can have stretching of the ligament. You can have continued instability and need revision. Tommy John. So it's not like Rookie of the Year where you get your Tommy John and then suddenly you're throwing 105 miles an hour.
Right.
It's surgery, and having surgery when you're 15 and having to take at least a year off from your sport is a big deal. So these are the topics we discuss in the office.
Yeah, that's great. And Cam, I want to dive into that a little bit more. The Tommy John epidemic is crazy. I mean, we had Jamie Reed on the show, long time Texas Rangers medical director. And he showed me a heat map from back in the day where Tommy John surgeries for high school baseball players, and it was just red in the southeast, the south, and blue, very cold, no minimal surgeries in the Midwest. And then he showed me one more current, and it was pretty much trending in the wrong direction in the Midwest. And we talked about kind of that weather aspect. Cam, from your understanding and your expertise, is there an age that's too young? Are there people, you hear these horror stories about parents like thinking it's going to improve, like do the Rookie of the Year stuff to their kids? Are there people that are really coming in and wanting that for their kids, or is that just kind of anecdotal stuff that you hear kind of throughout the baseball world?
No, I think the Rookie of the Year stuff is sort of more anecdotal.
Right.
What happens is kids will have elbow pain, and they'll just get an MRI, and they'll either have a partial thickness injury to the ulnar collateral ligament, and this is countrywide, so it's hard for me to know exactly what went on with each individual athlete, but my educated guess is that they're having a discussion. These kids are 14 or 15, and they're having a discussion in the clinic with the parents and the kid and the doc and saying, oh, well, you want to be a college baseball player? Well, we could do 6 to 12 weeks of rehab, and then we could do a return to throw program, and you'll probably miss the rest of the season. Or, and this may come back, and you may have elbow pain next year. Or we could do ulnar collateral ligament reconstruction. You'll be out the whole year, but you'll be back next year. You'll have no elbow pain, and you should have no elbow pain, and you should be ready for the scouts come junior year.
Sure.
That's my guess. If you have a full thickness injury and real elbow instability, and you want to continue to play and maybe play at a higher level, that's a different discussion. But I think there's a lot of gray area. It's interesting you mentioned the Texas Rangers, because Dr. Keith Meister is one of the, I think he's associated with the Rangers, but he's one of the world experts in ulnar collateral ligament repair and reconstruction. So he's one of maybe 2 or 3 docs that pretty much every major leaguer gets sent to.
That's right.
He's obviously very experienced and very good at what he does. And I think that has changed. You were talking about the heat map, and Riz, you may be able to speak better to this, but over the past 30 years, it used to be maybe the team docs would handle that. Dr. Gill would take care of that with the Red Sox or the Patriots. But it's now become 2 or 3 guys for 1 or 2 problems, and that's it. So every agent sends, all their players to Dr. Meister or Dr. Elatrosh or something like that. And I think that level of subspecialty has condensed over time.
Yeah, that's a great point. And we could have a conversation about youth arm health epidemics and Tommy John surgery for hours, I feel like, with both you guys. But I want to shift gears a bit here, guys, and kind of talk about the future of the profession of athletic training and sports medicine in general. You guys are two of the great people to chat with that about. Andrew, from your perspective, with so much data innovation, Brad Pearson talks a lot about AI and what they're doing in Boston with that. Is there a shift you see happening now and kind of what the athletic trainer role might look like maybe 5 to 10 years? I know you don't have a crystal ball. You're not a predictor of the future, but what do you think the profession looks like in the next 5 to 10 years of athletic training?
I mean, I would hope we would keep innovating and evolving as athletic trainers and healthcare providers. I think if we don't use technology to our advantage, you're gonna miss the bus. I think for us to provide the best care possible to the people that we're caring for, we need to use all the tools in our toolbox to be able to come to that decision making or that objective finding or that assessment. So for us, and for me particularly, I'm someone that always wants to learn more and how to best treat the population I'm dealing with, whether that's a track athlete, whether that's a baseball player, whether that's a fencer, whoever it is. How do we use those tools to make sure we're coming to a correct assessment? So then I can refer them to someone like Dr. Roth and say, hey, Cam, guess what? I had this baseball player in today. We actually brought him up to the field and we were able to do some motion capture. We caught this on his lower extremity push off the rubber, and we saw him drop his arm in the arm slot. What do you see here? And then we can at least put that data over to Cam. Cam can look at it. Cam can say, you know what, let's get him in the office. Let's take a look at him versus just a phone call, which does work. But for us, I think you have to be current, look into the future, and do all the research that you need in order to create a better environment for the people you're dealing with. And AI technology, I know it scares people, but it is something that's going to be very helpful for us to become more specific to nailing a diagnosis or an assessment so we can get that athlete back on the field or back to their work faster.
And Cam, on your end, whether it's imaging or surgically or anything you do every day, I know you mentioned you're 3 years into this now, but still very experienced. Have things changed, quite a bit for you in terms of tools you're using to analyze or view data or just data you guys can collect to make better decisions?
I think there's a couple things. I think seeing the injury happen is actually quite helpful. So all the players have an app on their phone that they can show, at least for the pitchers, they could show each pitch. So when I'm talking to the pitcher, this is recorded during the game. So they'll say, I got hurt in the spring training game yesterday. And I'll say, when exactly did it happen? Then we'll pull it up on their phone and actually watch the pitch, and then we can slow it down. So that's actually really, really helpful that I've found helpful. Motion capture is super helpful. So being able to see how people move normally and then how people move while they're doing their sport of choice. And again, it's not just baseball. I think this applies to everybody. And what's also interesting is this applies to rehab as well. So you can actually take motion capture and use it when you're doing your rehab exercises and when you're doing your home exercises. So you can track your home exercises and see, am I doing this correctly? Am I improving? And what has my trajectory looked like over the 4 to 6 weeks that I've been doing my home exercises? So more objective data, I think, is helpful. On the other hand, over the past, 15 years, you hear the word analytics being thrown around because people like to think that the more numbers you have, the more specific it's going to be. But we're also treating human beings. So just talking to people and sitting down with them and doing a simple physical exam is, 90% of the diagnosis anyway. High quality imaging is helpful, but that's a technology that's been good for a long time.
I'd add to that too. I think that Cam, you said, sitting down and listening to the patient. I think that's key with anybody working in the field that we're in. Just listen to what they're telling you and let your instincts help guide you. You don't need all the stuff that we're talking about. It's helpful. right? But if you know the athlete and you know the patient, you're going to really come to a better conclusion probably most of the time versus them just walking into Cam's office for the first time and talking to him. So the athletic trainer, as Cam mentioned at the beginning of this interview, that there's 250 athletes that you're dealing with. You know all those athletes. You know what they're going through.
Yeah.
So as an athletic trainer coming up in the profession, just open your ears and before you say anything. And if you do that, you'll probably have some good success.
Riz has been doing this for 30 years and I've been doing it a little less. And we've come to that conclusion through our training and through our mentors and on our own, and it works. But you know who really believes in that and who told us that is Dr. James Andrews. So that was his arguably one of his main points when we talked to him on our show, that listening to the patient, calling the patient's mom, or having the parents in the room and having that communication. He never talked about, more advanced imaging or bioinformatics or analytics. He said, talk to the patient, do a physical exam, and 90% of it will figure itself out on your own. So if he says it's, then I think it's gold.
Yeah, that's great. And I was just going to mention, we had Dr. Camp from the Minnesota Twins and Dr. Beacom as well with the Twins on the show a couple of times. And Dr. Camp specifically said, I want to be around the players and see them a lot, not because they're injured, not because they need something, but because when they come to see me, I don't want them, or if I walk in the door, I don't want them to say like the boogeyman's here. This is trouble. This is bad news. So framing psychologically that, hey, just because Dr. Camp's in the building, he's here to see you doesn't mean the world's ending. Cam, do you have kind of similar feelings on that in working with players?
Dr. Camp was actually a fellow at Hospital for Special Surgery when I was a rotating med student.
Okay, he's awesome.
And now he's a very accomplished.
He is very, very accomplished. That's for sure.
Sports medicine physician. Right. It's great to see how far he's gone. The relationship with the players is pretty strictly professional, I think. Mm-hmm. I mean, you'll see them in the hallway and say what's up and make some small talk. But I think maybe James and Kevin and those guys have a more personal relationship with the players. It's my job just to make them feel comfortable in the moments that I'm spending with them, and that I'm not there to end their season or send them to a different level of ball. So I think just being normal and omnipresent. I'm not as tall as Dr. Camp or something like that, so maybe not as intimidating. But just having that relationship, and I know Kevin and James have very strong personal relationships with the players and make them feel very, very comfortable. So it feels, at least for me, it feels like a slightly more relaxed atmosphere. However, sometimes when you bring some of these guys back into the back room and you have to tell them bad news, it's just like telling anybody bad news about anything in the office. So you just do your best to be personal, empathetic, and compassionate.
And you guys have talked about a number of so accomplished professionals who you just mentioned, Dr. Andrews, Dr. Meister, many that we've talked about today. And you mentioned at the outset about how mentorship and guidance is an important part of your show and teaching the next generation. Andrew, when you're kind of mentoring younger athletic trainers out there, is there there's obviously not one piece of guidance that is above everything. Is there a kind of biggest mistake or mindset that you help them try to avoid as young athletic trainers progress through their careers?
I think the biggest thing that we discuss and talk about when I get clinical students in is their ability to try to make a quick assessment, right? So for them, it's trying to understand what the differential is, what else could it be? How are you going to help that athlete get to the end of that, whatever the assessment is? How are we going to rectify this? And then trying to be as empathetic as possible, right? So I think the big thing Cam had mentioned, knowing the athletes, listen to the athlete. I learned this a long time ago, is that be an active listener. Don't just hear people. So focus on them, listen to everything that's happening, and understand them as athletes so you can help them better after. I mean, you can help the physical injury, right? But how do you help the mental side of that? And I'll give you just a quick example. So the other day, I had an athlete that came in with an injury, and unfortunately, it's a season-ending injury for them. They're going to have surgery. And the one thing that I said to her at the time, I said, let me know how I can help you outside of the regular rehab. If you need anything, you can always come talk to me. Because the biggest thing that I find that athletic trainers don't do a great job of is being available for, I say, the 10% above the shoulders. Like, how do we get you past this phase of recovery when you have that mental anguish? So for young athletic trainers, the biggest thing is learn the mental side of the game and how to manage it. Mm-hmm. And then if you do that, your athletes will be more apt to have confidence in you and what you can provide for them.
Yeah, that's a great answer. And Cam, on your end of things, I know it's a different profession, but still very similar in ways. What's your kind of guidance in terms of mistakes people could make trying to get into a position that you're in as a professional?
I think, and I was actually talking to one of my colleagues about this the other day, I think taking your training into your own hands and really getting the most out of that 5 or 6 years of residency and whatever post-residency fellowship training that you do, and finding your interest and finding your mentor within your program almost as fast as you can, and just following and emulating that person. So Riz has his mentors, I have mine, and then we also have, similar mentors that we've cross-collaborated with over the years, and emulate that person. And then also find somebody who maybe you don't want to be like, and then find all of those characteristics that you find that would not be helpful in your future practice, and try to do the opposite. And it's actually quite helpful. So you find someone with, below average bedside manner, and then you find someone with exceptional bedside manner. You find all the things you want to do, and then look at the mistakes that you could possibly be making, but someone else can make them, and learn, okay, this is what happened today with this patient or this athlete. I know not to say that, or not to act this way, or not to do that. And I know this other person treats parents like this, or treats athletes like this. Right. And this is who I want to be. And that's what I would do.
Yeah, that's great. And it's really cool to hear you both talk, very accomplished professionals. It still comes down to being a human, having a conversation, treating people with respect and the respect they deserve. So whether that's a young child or a parent or a professional athlete, sounds like you guys are in the business of treating everybody the exact same, which is awesome to hear. Well, Andrew, let us know, where, for the listeners out there on Inside Athletic Training, so much similarities between the show you guys have and ours over here. Let us know where we can find you, find the show, find your social channels, all that good stuff.
We're at Behind Sports Med Podcast on Instagram. We have a YouTube channel, Behind the Sports Medicine Podcast, and then we are also on all audio platforms, Spotify, Apple, at Behind the Sports Medicine Podcast.
And if you're on LinkedIn, we publish a newsletter twice a month that highlights our most recent guests, and then previews upcoming guests. So we just published our newsletter yesterday featuring Dr. Saurabh Shah, who's the Director of Sports Medicine Fellowship at New England Baptist Hospital. We had a great conversation about him, about the innovations of shoulder surgery. And then we're previewing our upcoming discussions with Kurt Schilling, formerly of the Boston Red Sox and Arizona Diamondbacks, and then Ellie Hart, who's an enormous name in gymnastics medicine, who works in Boston.
Awesome. Well, Andrew, Cam, really appreciate you both taking the time today. Great to get to know you better. I know our listeners are going to take a ton from the conversation, spanning a ton of directions there. Appreciate all you guys do for the profession, and we'll chat soon.
Thanks, Tim.
Thanks, Sam. Appreciate it.
Thank you for listening to this episode of the Inside Athletic Training Podcast. For more information about PBATS and the profession of athletic training, visit pbats.com. See you next time.